I want to tell you about a patient I will call Donald. Donald is 71 years old. He came to see me 18 months ago because his daughter was worried about him. In the previous year, he had started shuffling when he walked. He was forgetting words mid-sentence. He had fallen twice. He was sleeping 10 hours a night and waking up exhausted. His mood had shifted. He was irritable in ways that were out of character, and he had started withdrawing from his grandchildren because crowds made him anxious and overwhelmed. 3 different physicians had told his family that what they were seeing was early dementia. One had started him on an antidepressant. His daughter was researching memory care facilities. When I ran a full panel on Donald, his vitamin B12 level came back at 148 picograms per milliliter, severely deficient. I started him on intramuscular B12 injections weekly for 1 month, then monthly. Within 6 weeks, his walking had improved. Within 3 months, his cognition had cleared to the point where his family stopped talking about memory care. His mood normalized without the antidepressant. Donald did not have dementia. He had a nutritional deficiency that is extraordinarily common after 65, almost universally underdiagnosed, and in many cases completely reversible. My name is Dr. Rachel Storms, and today I'm going to walk you through the 5 warning signs that your body uses to signal B12 deficiency. Signs that are frequently dismissed as normal aging, misattributed to other conditions, or simply missed because the right test was never ordered. I'm going to tell you exactly what each symptom means physiologically, why it occurs, and what to do about it. And I want to flag something at the start. The 5th sign on this list is the one most commonly confused with early dementia. It is the one that is most frequently treated with medications that do nothing to address the actual problem. And in many patients, it is completely reversible when the underlying deficiency is treated. Stay with me through this entire video. Before we get into the signs themselves, I need to spend 2 minutes on why this deficiency is so common, specifically in older adults, because the explanation changes how you think about prevention and treatment. The primary reason is a condition called atrophic gastritis, the gradual thinning of the stomach lining that occurs with age. By the time most people reach 65, a meaningful percentage, estimates range from 10 to 30% depending on the population, have developed enough atrophic change in the stomach lining to significantly reduce their production of something called intrinsic factor. Intrinsic factor is a protein produced by specialized cells in the stomach lining, and it is absolutely essential for B12 absorption. Without it, B12 from food passes through the digestive tract largely unabsorbed, regardless of how much you eat. You can have a diet rich in meat, fish, eggs, and dairy, all excellent B12 sources, and still develop severe deficiency if your stomach is not producing adequate intrinsic factor. This is why doctors who tell patients with B12 deficiency to simply eat more meat are often providing advice that will not work. The problem is not intake. The problem is absorption. And this is also why oral supplements in standard doses frequently fail to correct deficiency in older adults. The sublingual and injectable forms that bypass the gut absorption mechanism are often necessary. There is a second contributor that many patients do not know about. Metformin, the most widely prescribed diabetes medication in the world, significantly reduces B12 absorption through a mechanism involving calcium-dependent membrane transporters in the small intestine. If you are over 65 and taking metformin, your risk of B12 deficiency is substantially elevated, and your B12 should be monitored at least annually. Proton pump inhibitors, omeprazole, pantoprazole, lansoprazole, which are among the most commonly prescribed medications in older adults, also reduce B12 absorption by suppressing the stomach acid that helps release B12 from food proteins before intrinsic factor can bind it. The combination of age-related atrophic gastritis plus a proton pump inhibitor plus metformin in a single patient, which is not an unusual combination, creates a nearly perfect storm for severe B12 depletion. With that foundation established, let us talk about the first warning sign, the symptom most classically associated with B12 deficiency in the peripheral nervous system is paresthesia, the medical term for tingling, numbness, or a pins and needles sensation, most commonly in the hands, feet, and lower legs. If you have been experiencing this and told it is just poor circulation or just arthritis or just getting older, I want you to hear this carefully. Peripheral nerve damage from B12 deficiency is a real and progressive condition, and the window in which it is fully reversible narrows the longer it goes untreated. Every nerve fiber in your peripheral nervous system, the nerves that run from your spinal cord out to your hands, your feet, your face, is wrapped in a protective sheath called myelin. Myelin is the electrical insulation of the nervous system. It allows nerve signals to travel at full speed and without interference, the way insulation on a wire prevents short circuits. Vitamin B12 is essential for the synthesis and maintenance of myelin. When B12 is deficient, myelin degrades. The nerve signals, including those that tell you where your foot is in space, whether the surface under you is level, whether you are about to lose your balance, become unreliable. This is why B12 deficiency affects not just sensation, but coordination and balance. The medical term for the condition is subacute combined degeneration of the spinal cord, and in its later stages, it produces a very characteristic wide-based, shuffling gait, exactly what Donald's family had attributed to dementia. There is a simple test you can do at home, carefully, near a wall or with a partner nearby, that can give you a rough sense of whether your proprioception is compromised. Stand on one foot, time how long you can maintain balance with your eyes open, then try with eyes closed. In adults over 65 with healthy proprioception, most people can maintain single leg balance with eyes open for at least 10 seconds. When you close your eyes, you remove the visual input that partially compensates for proprioceptive deficits. If you notice a dramatic difference between eyes open and eyes closed balance, or if you cannot manage more than a few seconds either way, this is information worth bringing to your physician. It is not a diagnostic test for B12, but it is a functional signal that your peripheral nervous system may be worth investigating. The second warning sign is what I call the cognitive shadow, a pattern of mental symptoms that looks from the outside and sometimes even to the person experiencing it, like the beginning of dementia. The specific presentation includes word-finding difficulty. You are mid-sentence and the word simply is not there. It includes slowed processing speed, the sensation that thoughts are taking slightly longer to form and connect than they used to. It includes difficulty with concentration and with holding multiple things in working memory simultaneously. And it includes a kind of mental fog, not amnesia, but a dulling of mental sharpness that the person themselves often notices and finds frightening. I want to be very precise about the distinction between cognitive symptoms from B12 deficiency and early Alzheimer's disease, because this distinction has enormous implications for how a patient is treated. B12-related cognitive symptoms tend to have a relatively rapid onset over months, rather than the very gradual years-long progression typical of Alzheimer's. They are accompanied by other B12-related symptoms, the tingling, the fatigue, the mood changes I will describe shortly. They do not follow the characteristic pattern of Alzheimer's, which preferentially affects episodic memory, the ability to form new memories, before affecting other cognitive domains. And critically, B12-related cognitive decline is associated with findings on brain imaging, specifically white matter changes and in severe cases cortical atrophy, that in some cases are at least partially reversible with treatment, particularly when caught before the changes have become extensive. There is a published study from the Oxford Project to investigate memory and aging, a landmark longitudinal study that found that participants with low B12 levels at baseline had significantly greater rates of brain volume loss over the following years compared to those with adequate levels. This is not a subtle association. The brain is physically shrinking faster in people with low B12, and in the subset of that population who had the deficiency treated, the rate of atrophy slowed. This is the kind of finding that should make B12 screening in older adults a routine annual blood test. In many healthcare systems, it is not. The third warning sign is fatigue, but a very specific kind of fatigue that has a specific physiological explanation and that does not respond to the interventions people typically try. The mechanism is this. Vitamin B12 is essential for the production of red blood cells. When B12 is deficient, the cells that mature into red blood cells in the bone marrow develop abnormally. They become enlarged and immature, a condition called megaloblastic anemia. These oversized, abnormal red blood cells do not carry oxygen as efficiently as normal red blood cells, and there are fewer of them. The result is that your blood's oxygen-carrying capacity is reduced, and your body's tissues, including your brain, your heart, and your muscles, are running on less oxygen than they need. The fatigue this produces is qualitatively different from normal tiredness. It is present on waking, not just at the end of the day. It does not improve with more sleep. It is accompanied by a persistent shortness of breath on exertion, climbing stairs, carrying groceries, walking at a pace that used to feel easy, that patients often assume is a heart or lung problem. And it includes a pallor to the skin and sometimes a slight yellowish tinge that reflects both the reduced red cell count and the breakdown of the abnormal cells. If you or someone you know has been supplementing with iron for fatigue without improvement, and the fatigue preceded the iron supplementation, please consider the possibility that the underlying driver is B12. Iron supplementation in the presence of B12 deficiency will not correct megaloblastic anemia. The bone marrow needs B12 to produce functional red blood cells regardless of iron availability. The fourth warning sign is one that I genuinely want you to check right now because it is a physical finding you can observe in the mirror in 30 seconds. The sign is glossitis, inflammation, and atrophy of the tongue. In B12 deficiency, the small projections on the tongue's surface called papillae, which house the taste buds, begin to atrophy. The tongue becomes unusually smooth. In some patients, it also becomes red and sore, a beefy red color rather than the normal pale pink. The taste buds embedded in those papillae are affected, and many patients report that food has lost flavor, or that they are tasting things differently than before. Some describe a metallic taste or a burning sensation in the mouth that has no obvious cause. I want to be very precise about the distinction between cognitive symptoms from B12 deficiency and early Alzheimer's disease, because this distinction has enormous implications for how a patient is treated. The fifth warning sign is the one I want you to remember most clearly because it is the most consequential and the most mismanaged in clinical practice. It is neuropsychiatric, changes in mood, personality, and emotional regulation that appear to come from nowhere. The specific presentations I see most commonly are persistent low mood or sadness without a clear precipitant, irritability that is out of character, anxiety, particularly a new onset anxiety, or an amplification of existing anxiety that the patient cannot explain, and in some cases, a picture that looks clinically identical to clinical depression, including loss of interest in activities, social withdrawal, emotional flatness, and sleep disruption. The reason B12 deficiency produces these symptoms is that vitamin B12 is essential for the synthesis of the neurotransmitters that regulate mood, motivation, and emotional stability. Specifically, B12 is required in the methylation cycle, a series of biochemical reactions that produce S-adenosyl methionine, or SAMe, which is the primary methyl donor for the synthesis of both serotonin and dopamine. Without adequate B12, the methylation cycle runs slowly, SAMe production falls, and the brain produces less of the neurotransmitters that maintain emotional well-being. The result is a mood disorder that is biochemically identical in its neurotransmitter profile to clinical depression, and that responds to antidepressant medications in the same way depression does, meaning it partially responds, never quite fully resolves, and returns the moment the medication is adjusted. What I see in practice, and what the clinical literature confirms, is that a significant proportion of older adults who receive a first diagnosis of depression or anxiety after 65 have undiagnosed or undertreated B12 deficiency as a contributing or primary factor. They are prescribed SSRIs or SNRIs. They have a partial response. They are told the medication needs to be adjusted, and the underlying deficiency continues to deplete unchecked. When B12 is corrected in these patients, particularly through intramuscular injection, which produces the most rapid restoration of tissue levels, the mood and anxiety symptoms often resolve more completely and more durably than they ever did on antidepressant medication alone. I am not saying antidepressants are never appropriate. I am saying that a B12 level should be checked before any older adult receives a new psychiatric diagnosis, and that this step is omitted more often than it is performed. Now let me give you the specific, actionable information you need to take into your next medical appointment. When you speak with your doctor about B12, ask for two specific tests. The first is serum B12. This is the standard test, and most doctors will order it readily. However, serum B12 has a significant limitation. It can appear normal or borderline even when functional B12 deficiency exists at the cellular level. This is because total serum B12 includes inactive forms of the vitamin that are bound to proteins and not metabolically available. The second test, and this is the one that catches deficiency that serum B12 misses, is methylmalonic acid, or MMA. Methylmalonic acid accumulates in the blood when B12 is functionally deficient because B12 is required to metabolize it. An elevated MMA with a borderline or even low normal serum B12 is strong evidence of functional deficiency at the cellular level. Some physicians add homocysteine to this panel. Homocysteine also accumulates when the methylation cycle is running slowly due to B12 deficiency. The combination of MMA plus homocysteine plus serum B12 gives the most complete picture. Regarding the threshold for treating, conventional laboratory reference ranges often list the lower limit of normal B12 as around 200 picograms per milliliter. But a growing body of neurological research suggests that symptoms, particularly neurological and cognitive ones, can occur at levels between 200 and 300, which laboratories report as normal. Many neurologists now use 300 as the functional lower limit for patients with symptoms. If your level comes back at 250 and your doctor tells you it is normal, but you have symptoms that match what I have described today, please ask whether a trial of treatment would be appropriate given your clinical picture. On the question of supplementation, if your deficiency is related to absorption, which, as I explained, it almost certainly is if you are over 65 and taking a proton pump inhibitor or metformin, or if you have confirmed atrophic gastritis, oral supplements at standard doses are often inadequate. The form of B12 matters. Cyanocobalamin is the most common form in supplements and the cheapest, but it requires conversion to the active forms in the body, and some people have reduced capacity for this conversion, particularly those with certain genetic variants in the MTHFR gene. Methylcobalamin is the active, bioavailable form that requires no conversion and is generally better absorbed and better retained in tissues. For neurological symptoms specifically, methylcobalamin is preferred by most neurologists. For patients with significant deficiency or significant symptoms, intramuscular injection is the most reliable route. It completely bypasses the absorption problem. In most protocols, injections are given daily or every other day for 1 to 2 weeks to load tissues, then monthly for maintenance. The response in terms of energy and mood is often dramatic within the first 2 to 4 weeks. Neurological symptoms, the tingling, the balance issues, take longer to improve and depend heavily on how long the deficiency has been present. Damage to myelin that has been ongoing for years may be only partially reversible. This is why early identification matters so much. The last thing I want to leave you with is this. The deficiency I have described today is not rare, not exotic, and not difficult to identify. It is extremely common, easily tested, and in the majority of cases, eminently treatable. What stands between many older adults and the diagnosis is simply the assumption, made by patients, families, and sometimes clinicians, that what they are experiencing is normal aging. Fatigue at 70 is not automatically normal. Memory changes at 72 are not automatically dementia. Mood shifts, balance problems, tingling in the feet, none of these are automatically the price of getting older. Some of them are signals, and this particular signal is one of the most valuable a body can send because it points toward a deficiency with a clear treatment and a meaningful chance of recovery. If you recognized yourself or someone you love in any of the 5 signs I described today, write B12 help in the comments below. I read every comment, and I will respond to as many as I can with specific guidance on next steps. Share this video with a friend or family member who has been told their fatigue, their memory, or their low mood is just aging. It may be the most useful thing that lands in their inbox this week. Take care of yourselves.